Targeted temperature management means a body temperature range between 32 to 36 degrees. Most experts, including myself, strive to maintain a temperature range from 32 to 34 degrees. The effect of therapeutic hypothermia is a reduction of neurological damage, thus a reduction of cell damage within patients after resuscitation. The objective of this cooling is an improvement of the neurological outcome, in particular not only a better neurological outcome in the sense of survival, but those who do survive, survive in a good condition. The use of the cooling pads is simple. As soon as the patient has been resuscitated, put in an induced deep sleep, sedated and relaxed, you can immediately apply the cooling pads. This takes perhaps 1 minute. Cover as much surface as possible, because the cooling rate and the cooling efficiency is directly proportional to the surface area covered. As soon as the patient is covered as much as possible, he should be placed in an ambulance and brought to the hospital. In the hospital, you should continuously monitor the temperature, preferably with an esophageal temperature probe. Theoretically, you could also use a bladder probe, but as the pad does cool quickly, you may find the bladder temperature to be somewhat lagging. Therefore, the more accurate temperature control is the esophageal method, which must show the monitoring temperature to stay between 32 to 34 degrees. This way the patient is not undercooled or too warm. Apart from targeted temperature management upon resuscitation, there are other medical indications for the cooling pads. For example, temperature management for any type of intensive care medicine or patients with heat stroke, where cooling pads can of course be used for rapid reduction in body temperature. A big advantage of the cooling pad is that you can already use it pre-clinically. This is a big advantage. They can be stored in a cooling case and then be applied directly to the patient. They are not invasive, which means no need to pierce the skin, rather simply glue it to the skin and then when you arrive at the hospital either replace it with new cooling pads or continue with other cooling methods. Again, these are the big advantage of the cooling pads. Not invasive and immediate availability pre-clinically. And the cooling pads cool very efficiently. There are a few studies that show the cooling pads have the highest cooling rate from all other cooling methods available. There has already been a lot of experience with the usage of cooling pads. For example, in Vienna, I believe they have been in use for the past 10 years, both pre-clinically through the Vienna ambulance service as well as in the hospital emergency setting. The targeted temperature management, mild hypothermia 33 degrees, has actually been the only therapy in recent years that has led to improved neurological outcome in randomized trials. There is no other therapy that has shown this effect.